Welcome everybody to Ask an Expert live Q&A for ADHD awareness. Hello, and we will also be talking about OCD today. So I am Tracy Ibrahim. I am one of the therapists in OCD and the Chief Compliance Officer. And I have two fabulous guests today that will go ahead and introduce themselves. Beth.
Hi, I'm Beth Keating, and I'm a licensed mental health counselor in Washington and Oregon, and I work here at NOCD. And I also run our ADHD and OCD support group. And I've been doing that for a while, so yeah, happy to be here.
Amazing. And Tandy?
Hi, my name is Tandy Cyrus. I am a licensed professional clinical counselor. I'm licensed in Ohio, North Carolina, Connecticut, and Massachusetts, and I work here at NOCD, and I'm excited to be here today.
Thank you so much for that. And of course, we are all here coming to you straight out of NOCD. You can find us on all of the socials. You can also go to nocd.com to schedule a free 15-minute consultation. We can talk to you about what we offer, payment plans. We are millions and millions of bodies covered by insurances. So don't hesitate. Go to nocd.com and click on the little consultation button. We also have a free community. You can download our app, it's a free app, and you can join our community where we have all kinds of good stuff going on. All right, so we are going to get started today. Somebody's probably like, where's Dr. McGrath? And the question is a great question. He's on a plane. He is on a plane. So you know what, though? We all are better looking than Dr. McGrath, and that's what's important. So now that you know that, I hope he's listening. All right, so I will take this first question because it's one of my most favorite questions that I ever get asked. Jack, what does ERP look like for someone with pure OCD? My OCD is all about mental perfectionism regarding my thought process or the answers I give. Same goes for my feelings, and I always have to feel right. Let me just start. This might feel upsetting to a handful of people, but there's really no such thing as pure O in terms of purely obsessional OCD. And I will tell you why. I know some people are like, I'm about to get up and tell her something. Well, I'm going to tell you facts. People with pure O have something that I like to call it is mostly O, as opposed to pure O. If you have ever, with your mouth, asked for reassurance, if you have ever confessed something with your mouth, if you have ever typed into your computer a search, those are all physical compulsions. That's why I call it mostly O. So let's just start with that. And number two is, what does ERP look like for pure O? It looks the same as it does for all O. Every single theme of OCD is treated the same because OCD is just OCD. It's in the same part of your brain, and the theme just describes the flavor or the way it's coming up for you. So but what would we do? We would look at your perfectionism. We would help you, instead of sorting through the answers you want to give or checking on your feelings, we would help you to understand that there are ways for you to disengage from those compulsions. I also noticed you said I have to always feel right. That sounds a little bit similar to what we call just right OCD. I'm not diagnosing you, though, because I'm not your therapist. Just throwing it out there. All right. Dun, 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 dun. Yes. All right. Let's see who wants to take this one. It says Dr. McGrath. So whoever wants to pretend to be Dr. McGrath can answer. Dr. McGrath, stand-in that looks better. Can you give some advice on how to stay strong and refuse to engage in ruminations or mental compulsions, which are sneaky, when the intrusive thoughts are so strong? Who's answering?
I mean, I could take it, but it is really, really hard. And it's about, just really challenging yourself to trust in the process. Because a lot of times I think that's why it's so hard, is because we just really, it's hard not to believe OCD and everything you've already done for so long to try to cope, and to try to resist can be really hard. But I love to encourage my members to use those response prevention kind of messages that remind you of accepting uncertainty or the anxiety, or that something would be difficult if it happened, and then like re-engaging in whatever you want to do. Like, what were you doing before these ruminations interrupted your day, or what would you rather be doing than ruminating? So that's
Absolutely.
yeah.
Those are facts. I always tell people you can't ruminate if you're not spaced out. I promise you, do a complicated math problem and ruminate. You can't, because if you are, your math problem is incorrect. Facts. Drop in the facts. All right. How about you know what? You know what? I'm gonna go out of order because I like to be not just right. Da, da, da. Tandy, any tips on how to, when you get intrusive thoughts that don't make sense, to not have it happen, or what to do?
That I think you would handle with just like any other intrusive thought. If whether the intrusive thought's making sense or doesn't make sense, you want to do the same thing, because we're still treating the intrusive thought. It's still an intrusive thought. So that's where you want to use your response prevention techniques, where you're using those statements a lot of times, like maybe this is going to happen. Maybe this won't happen, maybe it will. Learning to kind of lean into that uncertainty of whether it's something that makes sense to you or doesn't make sense to you. And then a lot of times, what I feel like OCD will do is it will not only convince you that something's going to happen, but it will convince you that you can't handle it if it's going to happen. So if it's something that doesn't make sense and you're like, how would I handle this? Just leaning into knowing that you're equipped to handle whatever comes your way, and you can handle that. I think that there's two parts there. It's knowing that you can handle the intrusive thought if it happens, and then wondering if it is going to happen.
Absolutely. One of my favorite things to say to myself, because I have OCD I've had it for 1,000 years, approximately. But one of the things that helped me break out of like rumination would be, and I use this with my members a lot, is this. It's a combo sentence. It's a little bit long. Maybe it's a run-on sentence, but it's helpful. Is this happening right now in this moment? If not, move on and do a values-based activity instead.
Mm-hmm.
Part 2, I'll deal with it if and when it happens. Right? It's like, what are you worried about right now? Stuff that's not even happening. Just saying. Okay,
Absolutely. And I love that you and Beth have both talked about the value-based activities. I don't feel like that they get talked about enough, and they can really take your mind off things. And not only that, OCD brings us down. It can cause us exhaustion, depression. And if you're doing those value-based activities, those things stay at bay a little bit more than they would if you weren't doing them.
Absolutely. Oh, this one is like handcrafted for Beth. Like practically has Beth's face on it. Any tips on managing increases in BFRBs while on stimulant medications for ADHD?
This is handcrafted for me. I was noticing that question. I was hoping you'd softball this one over to me, because I also run our BFRB and Tik support groups. So this comes up a lot in either group, when medications get in the way of, or just like anxiety or life or stress gets us on edge, and then that causes us to feel much more urges to want to pick or pull or bite or whatever the BFRB is. And that it comes down to, there's a couple things. First of all, you can see behind me here, I have this lovely quote that I talk to everyone about. It's like, we have to remind ourselves that urges aren't musts. We don't have to act on that. Doing a value-based activity that's maybe keeping our hands busy is the best idea. And having those things on hand during those times where you might be more likely to pick or pull, covering mirrors, things like that. All those like stimulus controls are really important. But you might also have to talk with your medical provider about if there's something else you should be doing, maybe come down off that, try a different med, things like that. Like, to some extent, you have to sort of balance it with what's helping your ADHD and what's making other things worse, and sort of try to find the middle ground, which could be really tough. So that's a good question, a good thing to talk over with your doctor. But trying to ride out that urge, riding the wave until that urge goes away by keeping your hands busy with other things. And then maybe trying to deal with stimulus control, like covering up those parts of your body that you might be eager to mess with, and or covering mirrors if that's something that is a trigger for you as well. So for sure.
Absolutely. I love that you mentioned like having things to keep your hands busy, because I always have things to keep my hands busy. I'm like,
Me too.
no, I'm ripping up a worm right now sitting here.
I know. I used to have, we gave out at the conference those cool little tote, like a little zipper bag with no CD on it. And I had a bunch of fidgets in there, and I think it's over by my side of the bed over there instead of right here, you know. But usually I'm pulling apart one of those too.
Seriously. And I think sometimes it helps when you have like different, maybe one time you want one kind of fidget or something to keep your hands busy, and another time you want something else. I keep a bucket. All right. See, we have a lot of questions to get through here. So this is just sweet. Thank you, Zebra Printers XD, for saying I'm an American hero. That's just cracking me up. Okay. Diamond, how do you stop feeling guilty for having insulting, intrusive thoughts about your family? Makes me feel undeserving of their love. Well, can I just say something about that? As somebody who has nothing but hardcore taboo themes all the time of OCD going on, mostly attacking people I love, so usually my family. My first most important thing is to remind people that we do not come up with our intrusive content, and therefore we're not responsible for it. If it's coming up, it means we care about it. So I kind of think of it as opposite reassurance. If it's like, you're going to kill your daughter, I'm like, wow, I must really love her. Because otherwise, OCD, if it said that about somebody, like, it was like, you're going to punch your rude neighbor in the face, I'd be like, yeah, that could happen. Actually, I feel pretty good about that. Like, thanks for the idea, right? So, I mean, so remembering that it attacks things that you care about, number one, and then number two, taking the guilt and shame out of it, because all the time I say to people, all the time, do you judge me for my insulting, intrusive thoughts about my family? It's like, no, not you. It's just me. I'm the one that deserves the guilt. And so being compassionate to yourself the same way you would with anyone else is the way to go. I really love, there's a workbook by Kimberly Quinlan called the Self-Compassion with OCD Workbook. And it sounds like you might need it. See, Beth keeps one handy. She eats them for lunch. She has one for every day of the month. So highly recommend that. All right, so let's see. What else we got? Nope, you answered that one.
Tracy, while you're looking through there, I'd like to piggyback on that and just say that, our brain at the end of the day is an organ. And I think that sometimes we forget that, and we think that we have more control over it. We would give ourselves a ton of grace if our kidney was misfiring or wasn't doing what it was supposed to do. But something about our brain, we feel like we have control over that. And intrusive thoughts, you don't. It's the same thing as if you're driving down the freeway and a car passes you on the left. You're just minding your own business driving. The car goes right by you. Same thing as an intrusive thought. It just comes in. It's not you thinking it. And sometimes just naming it will tame it. If you just say, hey, this isn't me having this thought. This is the OCD. I think that's helpful sometimes.
Yeah, that we can certainly get helped by understanding the fact of that as radical acceptance. Absolutely. And if you're doing response prevention, you definitely want to just lean into the uncertainty, right? You just want to say, maybe it is, maybe that's not going to happen. Absolutely. All right. So Zeus's pet has a couple of questions. I'm going to answer one of them here. Is clinical OCD something you are born with or not? And can a person not born with OCD develop OCD or a subtype of it at some point of their life? I just want to it's more of a clarifying question, which is there's just OCD. Okay, there's just OCD. You can't really get like a subtype without having OCD. So you have OCD or you don't have OCD. And if you follow the research, it's still a little bit up in the air. They don't have enough parent, child, or historical data to say 100% whether or not it's genetic. There's some things that say it is, and there's some things that say we don't have enough data for that. So, but I do want to say, yes, absolutely. You can develop late onset OCD or like later in your life. It can happen because of a trauma. So, and some people really, truly, they might be born with it, but you just don't notice it. Like I've had it since I was 4. I'm not sure if I was born with it. Probably I wasn't a compulsive baby because I don't know what I would have done. I compulsively cried, probably. I was like, man, I was like, that didn't sound right. I was like, all right, now it feels right. Maybe I was doing that as a baby. All right. This is an interesting one here. Let's see. Boo, 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 boo. How about this one? Who wants it?
I could start with some of the overlaps. A place that comes up in our group a lot is how, like, the checking, right? So OCD wants to check because it's really afraid it forgot to turn off the stove or forgot to lock the door or whatever. And when you have ADHD, that might actually be something you forget to do. This lady has ADHD and I left the stove on the other day. Came down and my partner's like, why is the stove on? I'm like, ooh, yeah, that was me. Sorry about that. So like that is a thing that happens. And so people are always like, but how do I handle like the fact that I actually do need to double check? But that's where I say, okay, so double check the one time. But be honest with yourself, because a lot of times if it's OCD, you do remember turning it off, but you don't trust your memory. Mm-hmm. And you're like, and one time won't be enough, typically. So it's being honest with yourself about it and being like, yeah, did I actually turn that off or not? Maybe. And then just like, looking and being, okay, that's enough, but not doing it over and over again and not making it repetitive. So that's something that has come up a lot as an overlap, is like when ADHD behaviors, OCD tries to overcompensate for some of that. And then it can get like really wrapped up into that.
Absolutely. And if you're desperately trying to figure out, kind of like what is OCD and what is not, stop trying to figure it out.
Yeah, that comes up a lot too. And I often will say, I don't know, maybe it's your ADHD, maybe it's your OCD, but
yeah,
let's figure out how to help you function.
That is legitimate. This next one, this is one of my favorite things. I talk about this quite a bit, but people who have coexisting OCD and depressive disorders with true suicidal ideation, especially when OCD patterns cause higher self-editing risk, researching, planning, etc. You're looking at it right here. I have persistent depressive disorder. I have OCD. I have truly suicidal ideation at times. And the way that we deal with that is 2 things. We do ERP for the OCD part. And we do behavioral activation therapy for the depression part. And you work with a specialist who can tell the difference so that you don't get misdiagnosed, mistreated, or potentially like what happened to me, because I happen to have suicidal OCD and I happen to have homicidal OCD. I happen to be depressed. And when I was 10, I got hospitalized. And from 10 till 18 and a half, I was hospitalized 29 times because every single therapist did not know. Every psychiatrist, every emergency room doctor got it wrong. So I cannot stress enough, as somebody firsthand, that I ended up having to diagnose myself after I became a therapist. That's how ridiculous it got for my life. So absolutely understanding the difference between a crisis suicidal situation and not that. They are clear as day. You can have thoughts, you can have images, you can have urges. You should not be researching and planning, because that, of course, is compulsive, just like if you were planning to save your family's life with a magical ritual. It's not going to do anything. So if you are actually suicidal, you are actually at harm to yourself, then what you are doing is moving toward a plan with intent, and you really want to carry it out. These are not distressing thoughts. These are not thoughts or images or urges that are like, oh no, do I feel that way? Is it worse because I'm depressed? All the questions and trying to figure it out, that's where OCD sits. And sometimes, because I have suicidal OCD, I'm like, is that a suicidal thought or that's real, or is it this? And I always go, you know what? I don't care. But if I start heading toward a suicide, actually acting something out, that's when you need to go to the hospital, go to the ER, go to call the police, go to the ER. It's much easier. Call 988, something like that. So, but yeah, taking part in those compulsions, such as researching and planning and all that, I don't recommend you do that. I don't recommend anyone does that. There's really no sense in understanding all of the options. Yeah. If you're considering options, you're already like, you've gone too far. No, just kidding.
I am really hopeful for the world that people are getting more educated, because I have a member who I've been treating for a while and she's doing great now. But when we first met, she had just been in the hospital for suicidal OCD, right? But they thought it was depression at first. So she did get admitted, but they were like, this isn't suicidal ideation. This is OCD. And she was like, oh, it is? So I was like, yes, it's starting to get out there in the world.
Yeah.
Because what you experience is unfortunate, it's terrible. And I hope it's not going to happen for
too many other people. That is absolutely no. And can you think of anything worse for somebody with undiagnosed OCD than to have to look on a board that says suicide precautions, homicide precautions, and then sit in a seclusion room with your intrusive thoughts being told that they're not intrusive? That's how you make people suffer. So yeah, go to a specialist, not someone that just says they're a specialist. Go to an ERP specialist. Why? Because ERP is the gold standard treatment for OCD. It has been for over 60 years, and you can get it at NOCD. Go to NOCD.com.
And we can do, for depression too, the behavioral activation, which is CBT.
Turns out we also do behavioral activation for depression. It's true. We treat people with all the things that you just mentioned all together. We're like, yeah, no problem. A lot of people are doing both of those treatments with. So love it. All right. Do you want this one, Tandy?
Sure, I'll take this one.
What's your best advice for thought diffusions and other obsessive behaviors for someone who battles chronic perfectionism stemming from trauma? Or not?
That's okay. I think in this situation, a lot of times it's good to recognize, okay, are we treating the trauma, which we can treat trauma at NOCD as well, but you want to figure out where it's coming from, and you want to treat both. If you're having a lot of trauma that's unresolved, you want to treat both. You want to treat the OCD with ERP, and then you want to treat the trauma if you need to with prolonged exposure. So I think that is one of the main staples here, is just figuring out, is it both? Is it one or the other that's more prevalent? When it comes to perfectionism, a lot of times, what I've seen that has been the most effective is just the ERP, where you're doing things and you're not double checking it, or you're doing things exposure wise and you're purposely leaving something out that's not perfect. So you're sending an email, or you're imagining sending an email where you've got a word misspelled, or where the paragraphs aren't just right. What I've noticed for most people that have the perfectionism is that it is all about just the exposures, and then the response prevention that will really break that up. And sometimes, the trauma does need addressed, but sometimes it's like, okay, maybe the trauma is what the underlying reason was, but it's still OCD. So we still want to get in and utilize that ERP.
Absolutely. Absolutely. All right. Let's see what else we've got here. What therapy is good for ADHD? Well, that's a Beth question.
It's a tough question. There isn't necessarily, outside of medication, any that are super strong evidence-based, but a mix of, like, it really depends on your own personal issues. If you're having a lot of difficulty with impulse control or focus, things like that, mindfulness might be better. It's a really hard one for us, but it does help us be a little bit more in the present moment. I've heard people doing DBT if they have a lot of interpersonal issues or emotional dysregulation kind of struggles because of their ADHD. CBT, obviously, just cognitive behavioral therapy can be really helpful. So it's not like OCD, unfortunately, where there's a gold standard therapy that works. So if you hear of that, that might not be, you might want to look at the research to actually see, but hopefully one day there will be better treatment.
I agree. Everyone does what works for them. I have two of my kids have ADHD, and growing up, it was just trying different things till I figured out what worked for them. It was visual charts. No, they don't see the visual charts. It was colored things. Also didn't see the colors of the things. I was reminders, frequent reminders constantly. A countdown. We're leaving in 5, 4, 3, 2 minutes. We're going in 1 minute. Are you ready to go out? Are your shoes on? All right. Do. And then as they got older, we transitioned to alarms. An alarm that goes off on your phone, because nobody walks away from their phone. I feel like babies have phones. They don't know how to use them. They rather just chew on them till they're old enough to start Googling.
For sure.
Yeah.
Well, and then you have to have alarms for your alarms, because you're not gonna do it the first time.
So
so mine literally says, seriously, take your meds.
See, this is how it works. And then there's rules you can't hit snooze. It's not an option. You have to get up now. Sorry. Punishment.
Well, and then I also like to put you have to sort of figure out how your life would be easier for you, not according to what everybody else would think. So we often leave our dishwasher wide open, because then it's easier to put our dishes in there and or put them away. It's almost like a holder. It's in the middle of our kitchen.
That makes sense.
Yeah. Things like that. So it's about that's why ADHD coaching, I think, is becoming popular. It's not evidence-based and people are not licensed, so be careful with that. But there are a lot of better therapists out there that, are cognitive behavioral therapists who could also help you kind of problem solve that kind of stuff in your own life.
Absolutely. Yeah, that's for real. Anything that says coach. Fun fact, not a regulated profession, because it's just anybody can coach anything they want. You can even go online and just do some stuff and then just print out your certificate. So don't be going to people thinking that you're saving money. You're just wasting time. Now all the coaches are like, oh my God.
Well, and it's not covered by insurance. So
because it's not a real service.
Yeah.
Facts.
So it ends up costing a lot. Yeah.
Just saying. All right. Not saying that there aren't some people that aren't good at coaching, just saying that it's not a regulated profession. So don't be like, oh, this person has a certificate in pickle coaching. Like, you know what? Maybe they make good pickles, but I can't guarantee it. And your insurance won't pay for it. So, all right. I don't know. What do you think about this one, Tandy?
Sure. I can read it. How come when you have one theme thought, you don't worry about the other themes at all? Thoughts don't bother you until it turns into another theme. I think that it's because when it comes into your mind, it is so strong that you kind of set so if you have your arms full and something's, more important to pick up or more prevalent, you pick it up and you set other things down. It's like that a lot of times with our OCD themes. And what I see OCD do sometimes is kind of like the old game whack-a-mole, where you hit the mole and it goes down and then maybe it pops up somewhere else. So I think it's like when that theme comes to your mind, that's the strongest. It's the newest and it's the most fearful. And the other ones you've kind of carried around for a while if you're not in therapy and not doing ERP. So you're able to kind of set them aside and then you're just super focused on this one theme. And then the other ones don't seem that bad. And then for whatever reason, that may go away. A lot of times I see this with relationship OCD. Let's say the relationship ends and then it's like, okay, I'm not having all those concerns about my partner leaving or an argument with my partner. So then the OCD or contamination OCD may pick back up. I think it's just all about, what seems the most distressing in that moment. And then the other stuff kind of feels like it's kind of just in the background, still kind of there. But what I always try to tell people and what I want to encourage people about is that we can manage OCD. So even though it seems like something's always popping up, we can keep that down with ERP. So find a therapist that specializes in ERP. Don't give up, try it. And every time you have a theme, just utilize a different ERP. And eventually you are going to be, you're going to be managing that OCD. OCD wants to drive your life, but you can put it in the trunk, and you can have control of the vehicle again. So that's what I feel like happens is a new theme will pop up. It's kind of the new thing. So we get hyper focused on it. And then the other stuff kind of is a little bit more quiet. And then for whatever reason, when that theme kind of dies down, the other ones will come back in a lot of times.
Absolutely. And sometimes you just have a ride or die, like my poo contamination is my ride or die, my suicidal OCD. And so I usually have approximately 4 to 6 themes going all at once, and they don't rotate. They just are all there. And I'm like, sweet. I love that for me. That's one of my favorite things to say. All right. Well, we have about 9,000 questions and 25 minutes. I feel like we can do this. It's happening right now. That's an approximate number. All right. So, all right, I'm just going to very fast answer this. How is hyperfixation different from obsession? It doesn't have to be. It could be the same thing. Hyperfixating could also be an autism thing. It could also be an interest thing. It could also be a perfectionism thing. So not much we can say about that, except that being obsessive about something feels urgent. Like if you don't solve it soon, terrible things will happen. And probably hyperfixation would feel more interesting.
It does, but it can also feel more, I think where it gets really confusing is like you can feel really irritated if you're interrupted while you're in a hyperfixation.
Absolutely.
So it does can feel urgent. And especially if you're like, if I don't do this now, I'm going to forget. And that's how you've managed to live your life. And then someone interrupts and walks in and tries to talk to you about something. And you're like, get out of my face because I'm going to forget this thing. So I could see where it can be really hard to like tell the difference. But again, we may never know exactly what the difference is. And we have to live with that uncertainty. Because that's
absolutely. ERP. I feel like the next 5 questions have to do with uncertainty. How do you handle a boss that makes fun of your OCD? Okay, that is not uncertain. Go to HR and tell them, A, Just, that's not okay. Bosses can't make fun of people, especially not for mental illnesses. Well, actually not for anything. They can't even like make fun of you for wearing a silly outfit. Definitely. That's very serious. Yeah. Go to HR. That's probably the best of the advice. Can trusting the process of ERP therapy turn into another compulsion? This is the one that I wanted to just say. Anything can turn into a compulsion, but if you're worried about it turning into a compulsion, you're compulsing by trying to worry about it. Stop trying to figure it out. Dr. McGrath's favorite thing is to flip a coin, and then you just decide whether or not it is, because it's irrelevant. All right. How about this one, Beth?
I find that imaginal exposures are hard for me as someone who has ADHD. I find that it's hard for me to focus on the exposure. Yes, this is a common topic. I don't necessarily know that imaginal exposure comes up, but just exposures in general, doing homework, focusing in session on the exposures comes up a lot. And so it's definitely tough. It is tough for people. And so usually I encourage people to go back to their therapist and tell the therapist they're having a hard time focusing on the exposure, so that therapist can maybe bring your attention back if they notice you going off. But also it's good practice for you to learn how to bring your focus back to it. Because you'd be surprised, but even people who don't have ADHD will often become unfocused during an exposure because they don't want to think about the uncomfortable thing. They don't want to be thinking about that. So it's a normal thing to have to learn to bring your attention back to it and to be focusing on that discomfort or that anxiety. But doing homework in general, like exposure homework, can be tough. And so my favorite go-to for people with ADHD to do their homework is gentle reminder apps where they can make a long list of like triggering words or phrases that just randomly pop up on their phone all day. So they have to be exposed.
I love that. That also helps answer this person's question who said that after grad school, they are drowning in figuring out whether to, feed the OCD or ADHD. And, the answer is don't feed anything. Just do the best you can do. Moving forward and take tips like this. Build it into your life. Build it into your life.
The ERP lifestyle is good for ADHD too, because a lot of what we're struggling with sometimes is that feeling of discomfort of like doing an activity we don't want to do, or that's not interesting, or things like that. So I encourage people to live that lifestyle too, for that same reason. Yeah, absolutely. I don't want to do the dishes because they're boring. So what can I do that makes it less boring?
That's legitimate.
Or just, oh, well, I have to do it anyway, even though it's boring.
Yeah. I used to struggle with brushing my teeth as a child because it was so boring. And as an adult, it became more boring because of how long I've been doing it. So I got an electric toothbrush.
Oh, I know. They're so much fun.
Tells me when I'm done with a quadrant. So like I know there's an end coming and I don't have to do anything. I just like move it slowly.
What we have in our shower? We have one of those car holders for your phone in our shower.
Oh, nice.
So that you could like enjoy your shower and like multitask by like watching live webinars.
Live webinars next time from the shower. We can't give medication advice. So if you have medication questions, go to your medication provider to ask said questions. And I just want to say yes, me too. And then we're going to go to the next question. How to stop thinking I'm actually faking having OCD and that I truly enjoy these thoughts when I don't, feeling like I have to react a certain way or else it'll come true. I get that constantly, honestly. I'm just like, do you even have OCD? Like, do you even, like, you're a faker and blah, 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 blah. What you do is you just stop. You have to stop. You have to just say, I don't know. And stop trying to react a certain way, because there's no certain way to react that makes something happen or not happen. Because before you started doing that, you weren't doing that and your life was the same. And when you compulse, your life gets a little bit worse with OCD. So, a lot of people are like, am I faking OCD? I mean, I've been treating OCD for like 25 years. I've been using ERP for over 20 years on my own OCD. And I still like do you even have OCD? Are those intrusive thoughts? And I'm just like, no, they are not. I am faking. Thank you. And then I go on with my day.
It's really interesting how many people come to us and think, I don't even know, do I even really have it? And that is almost a diagnostic tool in and of itself.
Yeah, I'm like, solved. You definitely have it. And I want to welcome some new people. Lamson, welcome. You were diagnosed with severe OCD. Interesting. Suicidal subtype. I was also diagnosed with depression, PTSD, and severe anxiety. Reached out to NOCD, waiting to get someone to call me. So you're going to get hooked up for therapy. Excellent. And I just want to say, for the record, there's no such thing as a diagnosis specifically of severe OCD. There's just OCD. So there's just OCD. There's also not a diagnosis of severe anxiety. There's just different types of anxiety diagnoses. So whoever told you that, just know, like, don't freak out and think like yours is worse than somebody else's or something. Like, don't. It's like, if I described to you how often I had intrusive thoughts, you would tell me I had severe OCD, and it's totally under control. But like at all times, I'm probably like 98% of the time I'm having intrusive thoughts. And they change. Like for the last probably solid week, it's about stabbing people in this soft spot right here specifically, because it's so soft. I just think I'm going to stab people and myself. See, in the soft spot. Okay, great. No problem. That is just an intrusive thought. Thoughts are not facts. And so far, nobody has been stabbed. So that's excellent. All right. Whew. All right. We don't have a lot of time, but we are going to go fast. Is it a bad idea to see two separate therapists at the same time, like one for ADHD and one for OCD? Could be, could not be.
Yeah, it just really depends. We often have members who come to us for OCD but keep their general therapist. They may even been referred to us for OCD because their therapist was smart enough to realize, I'm not a specialty in this. But it's just really important that your therapist for OCD and your therapist for ADHD communicate and talk and make sure they're not like doing things that would be, like interacting with each other or like
making OCD
getting in the way. Yeah, exactly.
Yeah.
Making OCD worse, getting in the way of it, that kind of stuff. So, it's really important that we as ERP therapists can talk to those therapists so that we can say, like, this is what we're going to be doing, this is what we're going to be treating, and have that line of communication open to make sure there isn't overlap. But sometimes it's better to have one who does both. But again, ADHD, there isn't really one really great treatment, and we don't necessarily treat that. I have many people with ADHD and OCD, and we might bring it in here or there, but like it's not what I'm treating. It's just me keeping that in mind. Like when I'm doing exposures, I'm like, oh yeah, this person has ADHD, so let me make sure they're focusing, or when they're not, probably they're going to struggle doing their homework, so let's talk about this gentle reminders app, things like that. So I'm paying attention to their ADHD, but it's not necessarily something I'm treating.
Yeah, and one of the best fabulous things, like maybe it's not the best, maybe it's like the first to second best thing about NOCD. The first thing is that we offer evidence-based treatment, and the second best thing, or equal with that, is we have an awesome free support group program for everybody who is in therapy with us. We have about 30 support groups that run across 7 days. No, we don't do 30 a day because there's not enough time in a day because there's only 24 hours. But we offer them across the week. And actually, Beth does run the ADHD and BFRB groups. And I run 2 taboo OCD themed support groups because I like to talk about that. All right, so you can go to nocd.com and find out more about how we can help you with a free 15-minute call. You can also follow us on all the socials. You can go to our YouTube, where you probably already are right now. Otherwise, you wouldn't be watching this live. But yeah, come on down. We can't wait to see you. Junie Tooney, I have OCD and now having panic attacks and anxiety. Are these related? The answer is we don't know, because we are not your therapist and we cannot diagnose you. But I can say this: 99% of the time, people who think that they're having panic attacks are having anxiety reactions because of OCD. Just really important to know that. So panic disorder is very different than anxiety that you get from OCD, maybe like and have a whole breakdown sort of situation. So just very quickly wanted to mention that. All right, let's see. People are glad they found this community. We are also glad that you found this. How about this one? With ADHD and executive function, I tend to break down tasks into steps, but then just right OCD comes in and I get stuck trying to maximize the most efficient way to do things. Any advice?
Yes, this is a great question. So this is where an ERP therapist would say, okay, so if you're breaking things down into tasks and then it doesn't feel just right, so you're like trying to maneuver or whatever, stop doing that and just follow whatever your original plan was, because that's the plan you came up with, or totally mix it up and do the thing that it says you shouldn't do or that doesn't feel right and do it anyway, even though it doesn't feel right. Because that's the ERP way of living.
That is the ERP way. I often do things that don't feel right and don't look right. You can't see it, but I have 4 pictures on the wall that is behind my computer monitor, and they are all crooked, and it bothers me every single day. Makes me want to rip my skin off, and that's why I leave it that way. I'm hoping someday I feel differently. It's not urgent, though. Okay, let's see here. Oh, hair twirling and pulling. We actually do treat trichotillomania. So just saying, yes, the answer to that is called habit reversal therapy. And we do have therapists that are trained in that at NOCD. But yes, the answer is habit reversal therapy.
There's also Comb B, which is extremely similar to HRT,
So similar.
if not almost exactly the same. They just have sort of a different way of tracking it. And there's actually a really fabulous book that about that I often recommend, called Overcoming Body Focus Repetitive Behaviors.
See that? She didn't write that book, so just know that's not why.
I did not write it, no, but it's a good book.
Yeah, that's how you know it's good. Because if somebody has a book and then they tell you to buy it, then you're like, you just think your own book is good. See?
Right.
Or maybe it is good. Oh, I love this one. Tandy, what do you think about often trying to avoid reading about other people's OCD obsessions because she fears that she'll start obsessing about that too? What do you think? Can you catch a theme? Are they contagious?
No, they are not contagious. I actually get this a lot with members that have like health, worried about their health, especially members that have allergies. So then, if they tell somebody that they have an allergy, then everybody will start talking about other allergies that are out in the world. And then they get, very anxious about that. But how you treat this is the same thing as you would anything else. We don't want to do avoiding, because avoidance is a compulsion. So if you're avoiding reading it, avoiding listening to it, then that's the compulsion, and that's keeping you stuck in the OCD cycle. So you want to interact with that, and then you just want to sit in the uncertainty of, maybe this is going to be a new compulsion. Maybe it's not, but I can handle it if it is, or if it is a new obsessive theme. because you're handling the other ones that you have. But no, you cannot catch a theme from somebody like a common cold. So you want to really lean into that and not avoid it.
Absolutely. I always say, can you imagine like somebody with OCD, right? Like I have OCD. I do ERP therapy all day. I would have had to catch every theme because not only do I read about it, but I set up exposures for people. They're telling me about their themes. Been doing it for over 20 years. I would have to have every theme, and yet there are still themes I have never caught because they are not contagious. So don't avoid. That happens sometimes in my some of my taboo support groups. Some people will be like, I can't like. Don't say pedophilia OCD. I don't have that yet. You know, I've never had pedophilic OCD, and I've been dealing with it for over 20 years with other people. I can't catch it. You know why? Because it's not contagious. It's probably just because I'm not worried about it. But yeah, it's real.
Yeah, I often will ask people or like suggest our support groups, and they'll be like, I don't want to because I think I'm gonna, and I'm like, nope, now you really have to. Now it's for sure our homework.
Absolutely. I will say that. I will say that as well. And you know, and it's not that like if we say don't think of a pink elephant, we all think of a pink elephant. So it doesn't mean you're not going to think about something because you heard something. Yeah. But it's also common. This is kind of I won't call it funny. I'll call it weird or entertaining or not entertaining. That sometimes during like certain holidays, certain people's themes will flare up. Like Valentine's Day, relationship OCD can get extra. During Halloween, I'll see sometimes an uptick in like themes that have to do with death or dark things. So for me, it typically fires up a little bit of necrophilia with the family, which, you know what? My family that has died so far, not hot enough for me to go cross the path to necrophilia. So I just allow those thoughts and images to be there and try not to throw up in my mouth and then go on with my day. Because, you know, it's a little bit gross, but I'm aware that I have OCD. And it's not really a big deal. So I don't treat those any differently than the other thoughts that come along, like stabbing people in this delightful soft spot. It's not because I heard somebody else. It's because for some reason, I touched the spot. I was like, oh, that's so soft, which my OCD immediately was like, which means a knife would go in it very easily. And I was like, yeah, that's true. You know, and then I put a knife on my desk and it just sat there for a long time. This is a great question regarding accommodations at work for ADHD, OCD, because you can't accommodate OCD and what. I will say, I will answer 50% of this question, and nobody's going to like me at the end of it. 0 accommodations for OCD. 0. Not at school, not at work, not at home, not with your mom, not with your grandma, not with all the people I didn't mention. 0 accommodations. Why? An accommodation makes your OCD worse. It's basically like somebody compulsing for you. Can you open the door for me because it's too dirty? Thanks, right? Or I'm going to spend some time ruminating. So can I get extra time on the test? No, you need to learn mindfulness so you can take your test while having OCD so you can function in the world. Or, oh, but what about going into the office? You know, I really just, it's contaminated there, or I have too many harm thoughts there, or it's so hard I have to compulse. So can I get an accommodation to work from home? And it's like, no, because if your therapist wrote you a letter for that, they wouldn't care about you. I promise this, because that would mean we are helping you become disabled from something that is not disabling and doesn't have to be. So if we said, oh, this person is not okay, don't let them go to work. They have to stay home to compulse. That doesn't make sense. How will you ever go back to work again if your therapist is telling you don't have to go to work, or you don't have to use the public bathroom on campus, or we're going to create a special situation for you? So that's how it works for OCD. And then ADHD, actually, sometimes there are accommodations, and those are very individual and depend on you and your issues and presenting stuff. Usually it looks like extra time on a test, quiet space to take a test with fewer distractions, I can't really think of any other ones. Fidgets, maybe you can have
Yeah,
a fidget.
fidgets in class. So like, I know this is talking about work, but yeah, like being able to fidget at work, or you know, having someone else take notes for you during a meeting or something like that. Yeah, it really depends on what your job is. It's really, yeah.
Yeah. What if you were a therapist with an accommodation to not do therapy while having intrusive thoughts? I could never work another day in my life.
No, or for me, like, I know I used to think I needed like certain accommodations for like notes or things like that, but I just figured out how to make that work in my own everyday world. And actually, NOCD helps a lot with that, because when we finish a note, it gives us confetti, which helps with the dopamine.
Yeah. That is legitimate. That is super legitimate. No, absolutely. We only have a couple more minutes. So what is the best thing one can do when the thought comes in, so and so committed suicide? So what if I get as depressed as them and do it? I have suicidal OCD. I love to share this question and an answer right now. It's just right here on my shelf. I had a very dear friend of mine complete suicide a couple of years ago, and my OCD, suicidal OCD, got on fire. So I made a picture of us and I keep it on my desk. And I got sexually intrusive thoughts about her. I got all kinds of different types of thoughts. I was like, she did it, so you're going to do it, because you never would have thought she would have done it. And so what do? I lean into it. I keep a picture of her because she's my friend. And also as an OCD exposure, in that just because I'm looking at somebody that died doesn't mean that I'm going to do that to myself, because thoughts are not facts and thoughts do not equal action. She clearly wanted to. I clearly don't want to. That is the difference between she and I. Even when it feels distressing, and yes, it always feels distressing, right? But the less you compulse, the less distressing it is going to feel. All right. I'm going to answer one, and then we're going to have one more, and then we're going to get going. Zenic, thoughts of other people during intimacy with partners, sometimes voluntary, sometimes involuntary. I have dealt with this as a sex therapist as well as an ERP therapist. And this is what I'll say. Is it a problem? That's my first question. If you're doing it voluntarily, then that's just something that, okay, then that's what you're doing. And that's fine. Some people are good sharing that. Some people are like, I better not share that. But as far as if they're intrusive and unwanted thoughts during intimacy, we just let them be there in the background, just like all the other things that we're doing, eating chicken or watermelon or candy or drinking coffee or having sex or shopping. Your brain doesn't go away during sex. Your brain is still there, luckily, otherwise it'd get weird. That's where you move into like necrophilia. But yes, so at the end of the day, you just have to let it be there. Sometimes I'll tell people, imagine that it's sort of a blurry image happening on your wall, kind of like a picture. So
I have to say, this is something that actually comes up for ADHD, because our brains will just like go to other places all the time, right? Like squirrel here, even when you're intimate with your partner or person. And so then OCD will sort of take over. Uh-oh, why is that happening there? And that's where you have to say, I don't know. It just did. Who cares? Whatever.
exactly.
Move on.
And some people do think of other things during sex, and that's not a problem unless it's a problem for you.
Yeah.
Right. Or if you confess it to someone that didn't want to hear it. Just throwing that out there too. All right, it's really time to go, but we'll answer one more question in a very fast fashion. How about that? What if uncertainty is triggering for CPTSD and developmental trauma? Well, okay, just really, really fast. I just want to say something. First of all, just so everyone knows in general, we've got a couple trauma questions. All trauma is not PTSD. Trauma is trauma. PTSD is a very specific diagnosis. Even if you've had like extreme trauma, sometimes you don't have PTSD. So just want to throw that out there. But any Anybody want to answer about how uncertainty, I mean, OCD attacks things we care about. So it's going to attack trauma. It's going to try to freak you out about it. That's very normal. Do we have any other things that we want to say about that?
Yeah, I mean, I think it's only natural for uncertainty about what if I'm going to get hurt again or whatever to come up. And it's hard if you have PTSD symptoms that are bringing up those past events. And then now you're also worrying about what's going to happen in the future. And what I would recommend is getting to a therapist who can treat both, like we can. I do that as well.
PTSD, chronic PTSD.
Yeah, I do that as well. It's called prolonged exposure, and it's fabulous. And it's actually, sometimes I like that even more than ERP because it's so transformative for people. Like,
I love
the difference from day one to like day whatever of us doing it is so fast and so different, and they just feel so like less triggered. So you're going to have then less of those thoughts coming up, and hopefully then you can be, when they do come up, maybe feel a little more prepared to handle the uncertainty with your ERP.
Absolutely. So ERP and prolonged exposure, they look about 75% similar and then about 25% different in prolonged exposure. And let me just say, absolutely, NOCD treats all of those things, but we have to assess it. You can't come in and be like, I definitely have this. Like, we have to assess it because we are trained professionals to assess. We can let you know if you have something, and if you do, how we treat it. So just want to thank everyone for coming out today, talking about ADHD and OCD and BFRBs and all the other things that we talked about. PTSD, I was like, there's so many letters, the whole alphabet that we discussed today. And hope that you can go to our website, nocd.com, schedule a call if you want to find out more about our services. Follow us on the socials, and maybe we'll see you in group or in session. So have a lovely night, everybody.
Thanks. Bye, everyone.
Bye.
Bye.